Good evening, everyone. And at the outset, I would like to thank the organizer, especially Dr. Rishabh, for inviting me. And we have a good panelist with good variety from different departments and modalities. So I sincerely hope we'll have an interesting discussion. Starting with our the representative case, and then what we'll do, we'll discuss the issues. And I'll say, let's directly go to the first issue. And I think in India, if you talk about head and neck cancer, if you don't talk about an oral cavity, that will not be right. So I think so we'll need to start with the oral cavity, and starting with those concepts which we use in the clinic, and that's something of resectable, border unresectable, or unresectable, but we'd like to have opinion from our surgical oncologist colleague. How do they define? Maybe Dr. Nikit Shah can start the comment.
So basically, unresectability for us is as it is clearly mentioned in the papers by Tata. So any buccal mucosa malignancies that is involving the skin and it is going up to or above the zygoma, or if there is a tongue malignancy that is going to the hyoid bone, reaching up to the hyoid bone, or it is going up to the vallecula. And for the tumors that are going above the notch, we practically call it unresectable.
Sir, your mic is on mute, sir.
My mic is on mute. Can you hear me?
Now we are able to hear you.
So, so we have to have a traditional teaching, which we all do know, that those patients having carotid involvement more than 270-degree, prevertebral fascia involvement, those high ATF means base of skull involvement, that no one touches it, and we know that that no one goes into it. But we do have certain situations where it is a big tumor, and we do worry about it, that is it possible to resect them with those good margins? And that is what Dr. Nikit was trying to allude to, defining them as per definition where it was done at TMH. Again, coming back to the same issue, does it remain the same for others? Dr. Rushit and Dr. Shashikant, maybe we can have their opinion on this. And this is what Dr. Nikit was referring to for the resectability. Dr. Rushit Dave.
Hello, sir. Actually, in head and neck cancer, as it is told, everything is technically resectable. But we usually use the term for borderline resectability, where proper reconstruction is not possible, with which we can give good functional results post-operatively. These cases are very large exophytic lesions reaching up to zygoma, high ITF involvement, skull base involvement, carotid encasement. These are unresectable cases, but usually these are the cases which are candidate for palliative chemotherapy. Most of the time, usually we go for palliative chemotherapy after neoadjuvant chemotherapy.
Okay. Dr. Shashikant?
Yes, sir. I would like to add more, like bilateral base of tongue involvement, advanced oral primary involving lateral or posterior pharyngeal wall. These are certain more cases which are, we feel, technically unresectable.
Okay, okay. So, Dr. Gunjan, he's the oral and maxillofacial surgeon. In your opinion, the same or different, or do you have some other definition for your unresectability and borderline resectability? Yes, or you don't have? Because I do have some people who said no, we don't have such any thing in our mind.
So I think this paper, the currently which you are showing, that is described 5 criteria about the borderline resectability. Like one amongst 5 were involvement of prevertebral fascia, the tongue tumor which are going up to hyoid and involving vallecula, or supranotch diseases which are going above the coronoid notch.
So it looks like by and large, our colleagues who needs to remove tumor, they do believe that there is a group of patients where doesn't fall into the category of absolute unresectability, but there is an issue regarding what kind of margin we are going to get. And as mentioned by others, just reiterating that if you have a tumor, that is when you put a finger there and you find that there is no gap between the tumor and the zygoma, then your margin is an issue where you're going to cut it inside. If you have a tumor up to vallecula, then in all probability, you have to do total laryngectomy to get a good surgery done. Otherwise, tongue is going to fall back behind. Then you have a hyoid involvement, similar issue. If you remove the hyoid, then by and large, you will end up doing total laryngectomy to these patients if you want to resect. And then, yes, maybe one can opine, carotid more than 180, how many times any one of you have resected? So I do hear this 270 always in the textbook, but traditionally my colleagues here also, they beyond 180, hardly ever I have seen them, they're going forward and removing. Anyone can take it, Dr. Nikit or Dr. Rushit. Dr. Rushit, ever removed a tumor having encasing a carotid more than 180?
No, sir.
No. So again, that also we have put in our when we put those criteria, that where can we have those patients where we can say this is a technically challenging and it is tough to have a negative margin, and in those situations one can provide some treatment and hope a group of patients they may become resectable. High ITF is not high ITF going to base of skull, it is above the zygomatic notch but below the base of skull. So the pterygomaxillary fissure should not be involved. That is what we had put the criteria. But I do concede this is not absolute criteria. There are people who have a variation in this and they do follow as per in their practice how extensive surgery they can do. Anyone wants to add anything on this? Those having the criteria for borderline resectability for oral cavity cancer.
So would like to add one more high level 2A node where we cannot get the IJV stump.
Okay. I agree with you. It's usually tough to fiddle in that area. Anyone else? If not, anyone from other department, any medical oncologist or radiation oncologist, they want to add it here? Anything from their side? If none, then maybe we can take it forward. So we talked about when we call it borderline or technically unresectable. We have used this word interchangeably, and in our various work which we did in this area. And then what we'll do is talk a bit about indication. We talked about the drugs, and then sure, we want to know that these are indications, but what kind of benefit is provided to the patient, and if you have it, what happens to the margin, and what happens to the adjuvant treatment, and that comes regularly when we do this kind of therapy in these patients. So this was one of our papers just highlighting that there was around 4 or 5 papers we had done with this, and this was the largest one with 700 patients and showing the similar result. Coming to the first to the benefit. So just trying to know from our colleagues from medical oncology, do you use this neoadjuvant chemotherapy in this setting? Maybe we can start from Dr. Akash Shah.
Yes, sir. We use chemotherapy in such technically unresectable patients, and we use 3 drugs regimens, TPF regimens for 4 to 5 days. For my experience, I would say it's not a excellent outcome, but around 1/4 to 1/3 patients will have good response and go for resectability.
बहुत बढ़िया. Thank you for that was a very important information. Dr. Nirali Trivedi.
Yes, sir.
Yes.
Good evening.
So do you use, does Nirav send any patient for NACT in oral cavity cancer?
Yes, so as you know, sir, our surgeons are very aggressive, but still there are patients definitely who still come under the unresectable criteria, like very, very large primary with bilateral multiple lymph nodes, gross carotid artery infiltration, or oral cavity going into the pharynx and all those things. We still use neoadjuvant chemotherapy, and which is usually the 3-drug regimen.
3-drug regimen. And what are the number of patients you think out of 10 you do, they get converted for resectable after that? Some number you want to put it?
Sir, I can say in our setting, it is almost 50%.
50%. Okay. So these are very important information. I'll come to that. I'll come to that.
Yeah.
Those numbers. Coming back to our surgical oncology colleagues. So you can put some number to it. Out of 10 patients you send for a new adjuvant, how many, when they come back, you are able to resect it? Maybe we can start with Dr. Nikit. Dr. Nikit, sir?
Sir, so the 3-drug regimen is a very effective regimen. Almost, as I feel, 50 to 60% of the patients can be resected. However, the issue most of the time remains about the margin, whether we should be taking the
We'll come to that. I know that margin is the way the response rates are very close to our heart. Margin is very close to heart of our surgical colleague. We'll come to that. So 60, if I take it, 60 you are able to resect?
My preference for the chemo is usually the 3-drug regimen. It is more effective, sir.
Okay. And 6 out of 10 you are able to resect subsequently. Dr. Rushit?
Yes, yeah.
Fair. That's good. Rushit, Dr. Rushit Dave?
According to me, the patients who are unresectable upfront while examination, around 2 or 3 out of 10 comes out to be resectable. In case of borderline resectable cases, the percentage is higher, around 60 to 70%.
Okay. So that's again a very useful information. Dr. Shashikant?
For unresectable, I think I would definitely send them for palliation. Frankly, unresectable.
Yeah.
For borderline, I mean technically unresectable, definitely I feel 50 to 60% would turn out to be resectable after TPF.
Okay. Dr. Gunjan? Because this number will be important, that's the reason I'm asking everybody.
Yes, sir. Yeah. Sir, I agree with what Dr. Rushit has said. Borderline resectable disease, almost more than almost 70% of the cases we get back for resections. So in those we can achieve R0 resection after NACT. But the diseases which are technically unresectable, only a few we get after chemotherapy, maybe 2 or 3 out of 10.
So I think so it is important what we heard from everybody, and that's because as I suggested that what kind of indication we use, that shows what number of patients finally we get back to having surgery. And in our series it was around 40, but I totally agree it varies, especially this people where you have those tumor around zygoma, the chances of they going for surgery is a bit higher. Again, for high ITF, there is a very narrow band of error there. That is from pterygomaxillary fissure involvement or not. If it is involved, usually they don't come back for surgery. If it is not involved, then yes, again, almost half of them, they go for surgery. Higher, again, it's a touch and go. If it is involved, then hardly anyone. If it is, there is a smallest of the gap of few millimeter also, then again you have a 3-4 out of 10 who come back for surgery. So again, that's the reason it varies from what kind of patient we have chosen, and that decides the number. What is important here is if they get resectable, this is the curve you get. If they don't get resectable, this is the curve you get. So if resectable after NACT, they do better as compared to if they don't undergo surgery, usually they are non-responder. So if you take overall the number, half of the patient, that is at 2 years, almost 50% patients survive, suggesting that at 2 years, 25% of 100 odd patients, they do really benefit with this approach. Yes, 75% they don't, but if you don't do it, then all of them, they go for either radiation or chemoradiation or palliative systemic therapy in that setting. So that is where the overall benefit lies in this setting. This was regarding the benefit what we received. Now coming to adjuvant, and coming back to our colleague Dr. Ankit, adjuvant, what do we do? So surgery has been done, and you have NACT being given, whole staging has changed. So how do we decide for those adjuvant treatment in this setting? Is there any way, or?
Sir, depending on the primary staging only, we can go ahead. And even after NACT and surgery, what is the YP stage or YPT and end stage, depending on that also we can give adjuvant radiation as we routinely give.
Okay, either YP, great. YP has N2 becoming N0.
Yeah, still will radiate, sir.
Still will radiate. Okay. Maybe we can have opinion from Dr. Akash.
Yes, sir. So it's almost all patients we should consider chemotherapy and concurrent CTRT, because it was already borderline resectable. So it was a high stage disease. But yes, sometimes if patient comes with like YP T2N0 disease, T1N0 disease, then I don't I don't add chemotherapy and just only radiotherapy, because the problem is to what chemotherapy drug will add. That's a different question. So for that, I don't add.
Yes, we'll come to that. Dr. Nirali?
Yes, sir, definitely we look at the histopathology report before deciding whether to add chemotherapy, but radiation definitely these patients would require. And if they are, anyway, extracapsular spread or something like that, definitely we'll have to add chemotherapy. Yeah.
So, so we had a mixed answer, and that's the reason is because we have given those, we are tampered with the usual treatment. We have given something upfront. What we did in our this group of patients, there were a good number of patients who didn't take any adjuvant. Because good number of patients, they get referred from TMH outside. So good number of them didn't take adjuvant, and that gave us a chance to compare adjuvant, that is CTRT versus nothing. Unfortunately, we don't have a comparison of RT versus chemoradiation. So no doubt adjuvant is required, and I'm sure that's no doubt about it, because all of them are beyond T3, so there's no question about that. For CTRT, there was a very good comment, and comment was these were not usual T4s. If they were T4 also, they were like big T4s. These were not those T4 which were taken in the chemoradiation trial of NEJM, which was published. And in those also, there was some merit to give those chemoradiation. So there's a merit that if you're taking these patients for neoadjuvant, because the patient has a bigger disease and borderline resectable, it is good to give adjuvant therapy. Yes, there is a challenge what to give, and we'll come to that. So we have some issues beyond that, which we talked about, and we will take this another important issue which our colleagues pointed out in the start, and I said I'll come back to it. What happens to margin? And that is, I'm sure, so close to heart of my colleagues here. So maybe we can start with Gunjan. Gunjan, original margin, revised margin. If revised margin, what do you do?
Sir, I think people have been saying about we should follow pre-chemotherapy margin, but it's a myth. We cannot actually practically go for pre-NSCT margins, especially for borderline resectable and some unresectable cases which have become resectable now. So for those, it is impossible to go for pre-anesthetic margins. And it is difficult to mark exactly radiologically or clinically what was pre, but still preferably we go for pre-anesthetic margin.
Okay. Niket, sir?
Yes, sir. Sir, like Gunjan Bhai said, it is always better to get the pre-anesthetic margins, but likewise, it is almost not possible, and especially in the patients with tongue cancers where it is crossing the midline, and we give neoadjuvant chemotherapy. Although we try and abide by the principle, but yes, almost it's not always possible. So frozen section might as well help during the surgery to give an idea about the margins.
Dr. Rushit?
Yes, sir. Actually, pre-anesthetic margins should be taken, but most of the time patients usually comes first after taking chemotherapy. We don't know what the previous situation was. So most of the time it's not possible.
Okay. Good, Dr. Shashikant?
If I have to take pre-anesthetic margin, then I would prefer to go ahead with upfront surgery. As we are talking about technically unresectable, then definitely post-anesthetic margin I would prefer to take.
So this is a very nice discussion on this issue, and this is our own data, so I put it. I'll share two more just to highlight the data so that it can help us decide. So I totally agree with you. We want to be. I know this is a very fair comment. If it was resectable upfront, then there was no question of giving in oral cavity cancer. There was no question of giving induction chemotherapy. One should resect it upfront, because we had an issue regarding what can do. Are we getting at least 5 millimeter margin or 1 centimeter? We can keep debating about it. Usually we say at least after surgery, after everything, after pathology, we should have at least 5 millimeter. Otherwise, upfront around 1 centimeter. If you don't have it, that's the reason it has been prompted that one wants to give some chemotherapy. And this is our data. That is a match pair analysis for upfront surgery, T4 tumors where it was T4 tumors where we gave NACT and borderline resectable, so bigger tumor, but looks like margin positivity doesn't increase. There was a Lisa Licitra paper which was against the revised margin, and the Lisa Licitra paper was a negative study. Resectable tumor, and the trial was done in resectable tumor. The chemotherapy given, then surgery versus surgery upfront, and revised margin did not lead to more loco-regional recurrence in those patients. Third paper, which again our paper, which I'll come back to after some time, that is a mandibular preservation trial, which was done from Tata Hospital, which is a JCO paper, came recently. And again here, to preserve the mandible after NACT, we had taken a revised margin, and again found that it doesn't lead to more loco-regional recurrence to the patient. That doesn't mean to say I'm ever conveying that compromise your margin. No, you shouldn't compromise margin, and that's absolutely right teaching, that margin has to be wide. Margin has to be wide, but it will be new one. In the Licitra, they had taken 1.5 centimeter from what you can see clinically, palpate clinically. So take a bit wider from what you can palpate clinically, and by and large, you don't get positive margin if you do it. But I don't mean to say otherwise one should compromise margin. Compromise margin is that when you are again palpating tumor and then taking a margin which is closer, and then chances of it being positive is high. Anyone wants to comment on this, what I spoke? We'll be happy to listen to the view of anyone. Go ahead.
Sir, there is a question from Kaustubh sir that NACT for borderline versus NACT for organ preservation is a different thing.
Yes.
And a comment, suppose sir there is a midline crossing and we have to go for more than hemiglossectomy, or there is posterior 1/3 tongue involvement and we are supposed to go for total glossectomy. if we are treating upfront. Now, post NACT, there is good response and we are able to do hemiglossectomy. So is hemiglossectomy good enough, or we should do total glossectomy as it was supposed to be done upfront?
So,
whether for organ preservation or less morbid surgery in resectable cancer, for less morbid surgery, can we give NACT?
At this moment, no, we should wait for it. We need to do a study like mandibular preservation trial was done. A similar kind of work needs to be done in these situations to prove that in those settings for organ preservation, one can do this part. Exceptional, we all do exceptional as an exception in many situations where patient is not willing for those routine treatment. But for a routine treatment, apart from preserving mandible in oral cavity cancer, I won't be someone who will advocate a neoadjuvant chemotherapy to preserve the organ. I hope that answers that question from.
Yes, sir. Yes, sir. Thank you.
Yeah. So we go ahead to another question which keeps coming up again. For if we give NACT, we are always worried about the complications. Maybe if we can have some experience sharing. We can start from Dr. Gunjan. More complications, less, same?
At times, sir, we may get complications in reconstructive surgery. The condition of vessels may not be that good compared to the upfront surgery. So that may be the complication.
Okay. Dr. Shashikant, because
yes, totally agree with Dr. Gunjan. Some healing issues and infection also may add on, and definitely for microvascular, the intimal edema and some issues would be there for sure.
Okay. So we did this analysis, and there's a data also from the Chinese group, and they did surgical complication. Looks like it is similar if we take care of a patient while giving NACT. So it doesn't add much to the complication, and that's what we observed in most of this organ when we are given neoadjuvant chemotherapy, like esophagus or you do bladder and other places. But I do agree we need to be a bit careful about it. Coming to chemoradiation after surgery, which chemotherapy? Dr. Akash?
Yes, sir. So it depends. So sometimes we have delivered 2 cycles of TPF only. So it's almost 170 to 190 160 to 170 milligram of meter square of cisplatin. So at that time, I would prefer to deliver weekly cisplatin. But if 3 cycles of TPF delivered, then I give carboplatin only.
Okay. Absolutely fair, but I know what Akash wanted to convey. Be careful when you're giving cisplatin a few cycles before you start CTRT. Dr. Nirali, your view and your practice?
Sir, if the creatinine is well preserved, then we usually prefer cisplatin. If the patient is frail and creatinine is slightly, IRFTs are slightly deranged, definitely we prefer carboplatin.
So I think so. It's fair to be cautious once you have given neoadjuvant chemotherapy with cisplatin, later to give cisplatin, especially 3 weekly. Remember, there is one European Union label also for docetaxel cetuximab, which we don't use commonly, but that's something again. Yes. One can use it where you are in doubt, but I'll leave it to. I also have hardly used it, but yes, that's option there. Dr. Ankit, radiotherapy, which kind of planning? What will be again your margin when you plan?
Almost same, sir. Flap plus neck nodes.
Okay. And the tumor and GTV and PTV, original or no? Post resected area. Original.
Mostly, yeah, mostly the resected area, because if it is R0 resection, all the whatever the tumor was there already been removed. So we will take the tumor bed plus neck nodes depending on the end status.
Okay. Thank you. So any special one or conformal will do, or IMRT or some better planning is more important here?
Yeah, mostly sir IMRT or VMAT or Epidan.
Okay. Coming to another issue which comes up for NACT is compliance. So Akash, in your practice, compliance?
So sir, are you asking during the NACT periods?
The whole treatment compliance, because compliance, if I say only NACT, then Nikit and Gunjan will not like it. He said, the whole treatment is to be planned. Don't tell only about NACT compliance.
Yes, sir. So that is compliance is not the major issue, but few patients it's actually very good response and size reduces nicely, like tongue lesion disappears. So such patients they don't want to do surgery and they run away. So actually such patients have a good response and we want such patients to get surgery done. But otherwise compliance is not the issue, sir.
Thank you. Dr. Nirali, same view or different?
Yeah, sir, same. If you have selected the patient well, they tolerate the treatment also well. And since they are responding well, they usually complete 3 cycles comfortably. Especially if we give 5 days, usually the neutropenic complications are more. If we restrict to 3 days, they tolerate it very well.
So NACT brings out its own issues, and that's why I thought I'll bring up this issue. One needs to be a bit on the toes. Otherwise, for patient responding and they do leave treatment in between, or some complication creeps in, and then you feel really sad for it. DPYD testing, anyone does it? Dr. Akash or Dr. Nirali? If you
Not
give IFU?
Not routine. If there is too much side effects, then yes, before second cycle.
Before second cycle.
We don't do, sir, honestly.
Honestly, okay. So we also started, sometime back, and we were not certain, and then we realized there's some merit to it. But I leave it to. I agree, not routinely people do use it. More data has come that it merits. Only problem is that, which I wanted to share, and we learned it hard way. And when we do send for testing, we don't wait. We start treatment, and we lost, the patient which was homologous, and then we realized that homologous, if you have DPYD mutation, then almost there is 100% mortality, and that was learning it in a tough way. But I thought I'll share the data, but it's a very uncommon. We have got till now, when we do DPYD routinely, we may not have more than a dozen patients who has got homologous, so it is not so common. But thought I'll share with you. And this was work done at TMH by a head and neck group, and it is part of NCT guideline, ICMR guideline, which I showed you. This was completely work done in India. So, but that's the reason I thought maybe, because it's our practice, what we do it, I'll be sharing with you. This was for oral cavity. One more work which was important, which just got into JCO recently. Any role in improvement in survival? Dr. Nikhil, want to comment? NACT in oral cavity cancer resectable?
That's a retrospective data from Tata, and that says that there is an improvement in overall survival.
But we don't,
in NACT. Yes, sir. But frankly speaking, I don't think so. But I see the role of NACT in the patients who have extensive paramandibular disease where the mandible is not involved, and post surgery, and if we are not giving NACT and where we are supposed to remove the entire mandible, but this cohort of patients seems to be a good candidate for NACT as it allows us mandibular preservation.
Dr. Rushit, sorry, Nikita, you want?
No, sir, that's it. I'm done from my side.
Dr. Rushit, resectable disease, NACT, improvement in survival? So Rushit is not there, but I think so. I'll echo what Dr. Niket said. Resectable disease, if you're giving NACT, you're not giving to improve survival because it doesn't. Yes, this is the work done at TMH, where we were trying to preserve mandible, and Dr. Niket suggested that yes, paramandibular disease where mandible is not involved in the scan. That is the important criteria, and then yes, you can preserve around 50%. Anyone uses this in the clinic? Dr. Shashikant or Dr. Gunjan?
So frankly speaking, for paramandibular disease, we are going ahead with upfront surgery, segmental mandibulectomy and reconstruction with any bone flap. In my my experience, probably I'm not using.
You're not.
The same views from my side. Sir, in a prior practice, it is if you are having a good reconstructive team with you, so it's always better to go for upfront resection and go for reconstruction. So because even after marginal ventriculectomy, the complications are pathological fracture or osteonecrosis that is very high. So it is better to go for such practice.
Okay. Okay. So this is nice to hear. It's important that one can have data from one center, but it's very important to hear from everybody. Dr. Rushit is there in case he's there?
Yes, sir.
Yeah. Have you ever used for preserving mandible?
No, no, sir. No,
Any
sir.
plans to
Same
use
as,
in future?
no, sir. We usually go for upfront surgery.
So Devendra has not impressed you all. I'll convey to Devendra that he needs to do a better trial. No, this is all for us. I'm just using his name here. We need to. I do agree with you. I know this is something which has got discussed many times, that if you're doing marginal and then if the fracture happens later on, then how is what happens to the patient? And yes, there is that challenge. Let's see. We are running the phase 3 at this moment. Have I short up the time? I think so. Rushabh, do I have some time, or how much time I have to wind up?
Sir, you can go ahead, sir. 5 minutes is there.
5 minutes?
5
okay,
minutes,
yes. I'll wind up in 5 minutes. This is another situation where we have explored some early striders. How comfortable you are that every strider, is there something called early strider? Maybe we can ask our surgical colleague, Dr. Nikhil.
Not that I know of that there is an early strider, but yes, when the patients do have difficulty in lying down position, we might call that an early strider, but I don't know about early strider.
I don't know. I take your point. Dr. Rushit, anyone? Any early strider? Okay. So this is, anyone wants to share about it? So if not, okay. So this is one situation where again we have used neoadjuvant chemotherapy. And if you see the CTC criteria, they do classify early strider where we can give some medical treatment and I don't have to put the tube. And one of the problem in these patients are either you do surgery, great, go ahead. If one is planning for organ preservation, then one can land up in a problem and it becomes tough to deliver CTRT, especially if the tracheostomy tube is there. Dr. Ankit, any experience with the tracheostomy tube and giving CTRT?
Yes, sir. A lot of patients come with after doing emergency tracheostomy, and we are doing it. Yeah. But I think tolerating very well, not a major issue.
Okay, okay.
But yeah, after NACT also they come and we do that also.
Okay, so in these group of patients, we have early strider. We tried this NACT, and usually those patients by 3rd or 4th day they became better, and after a cycle they went for CTRT, and just sharing that in case you get those early strider and in case you think tracheostomy you won't want to do it, is those very early strider patient. This is one approach one can use it, and this we use routinely otherwise also, but these patients are not so common. What I'll do is in 2 or 3 minutes, we'll just try to highlight other situations where we can use induction chemotherapy. But that's what the role has been given for me to talk about. Talking about pharyngeal, hypopharyngeal and laryngeal cancer. A role of induction for organ preservation. Dr. Akash and Dr. Nerali, any comments?
Definitely neoadjuvant chemotherapy with the 3-drug regimen.
Okay. And Akash, the same?
Yes, sir. Means if less than T4 disease, then yes, neoadjuvant followed by, if it's less than T4 and requires laryngectomy, then neoadjuvant chemotherapy followed by CTRT.
Okay. Dr. Ankit, you agree with both of your colleagues?
Yes, sir.
Okay. Oh, good. Okay, good. So I do agree with that. Hypopharyngeal cancer and laryngeal cancer, both you have. And hypopharyngeal cancer, in fact, that was the only randomized trial. And laryngeal cancer, yes, induction chemotherapy or concurrent chemoradiation both have got a similar weightage to preserve organ. Only one important thing to remember, which was talked about earlier, if you're doing this induction chemotherapy, be careful with CTRT. Giving 3-weekly cisplatin will be a challenge in this setting. Nasopharyngeal cancer, Dr. Nirali, induction chemotherapy, adjuvant chemotherapy, or both?
Induction, definitely yes, and mostly till now we have used the TPF regimen. And adjuvant, yeah, if it's a very huge tumor with the big nodes, we definitely give adjuvant also along with the radiation.
What capecitabine, metronomic?
If the patient is tolerating well, we give cisplatin.
If it's cisplatin, no, and adjuvant, I'm saying, and after induction CTRT, then adjuvant.
Sir, not capecitabine actually.
Not
Sir, we give oral gefitinib or maybe oral Oxan MTX.
Okay, okay. Dr. Akash, similar or different?
Yes, sir. Means I prefer induction chemotherapy because it's very easy to deliver. It's gemcitabine platinum, and after CTRT, I don't give anything. Sometimes patient directly started for the radiotherapy. Then for adjuvant, it's cisplatinum and 5-FU, but it's too much mucositis is there for adjuvant. So for that, I would like induction for nasopharyngeal.
Okay. So, so looks like no one has been enamored with metronomic capecitabine data till now. So maybe with time we will see. So this for nasopharynx, and absolutely rightly said that induction chemotherapy, or adjuvant, one of them one needs to choose. By and large, there's now some decent data for capecitabine as a maintenance in a metronomic setting. Looks like again promising in that setting, but I agree, we also don't use it at this moment. We also use induction chemotherapy followed by any other query, comments by any other panelist?
Sir, my point is that, sir, what about the chemosensitivity that we routinely see in a CA breast cancer? Say, see, if we give neoadjuvant chemotherapy and if it is progressed, then we suggest that it's a very bad prognosis in CA breast. Does it similar to head and neck cancer, that if we give a TPF and disease progress, then we have lost a precious time for surgery, or we can say that it's a very bad disease?
So first part, when we're giving induction chemotherapy in technically unresectable patient, if the disease progress, then also you're not losing time, because otherwise also the patient would have gone for chemoradiation or radiation. So you don't lose anything in that. I do concede that in the patients who are resectable, and that's a bit of a challenge. But having said that, it has not appeared in any of those induction trial. This is a good hypothetical reason which goes against induction chemotherapy, but that's not something which has ever been proved in the clinic, that losing of those time impacts the outcome. It does select those patients who will do good or who will do bad, because 7% patient in breast cancer also do undergo, they have a progressive disease, but we use them in routinely. Same in lung cancer, N2 disease, 17% patient has a progressive disease on NACT, but we use them routinely. So maybe that's not the right way to interpret. But having said that, if the resectable tumor is there in oral cavity and it's not going for mandibular preservation, then I'm not serving any purpose for the patient. Then I will not use it, because then I'm giving a treatment which I'm not certain about how I'm going to benefit the patient.
Thank you, Kumar sir.
Yes, one second, sorry, yes. Sir, sometimes you said in early stridor you give chemotherapy. So what is usually preferred? Do the patient still tolerate the 3-drug TPF in early stridor?
Okay, very well. What we do is we do 2 drug. We don't do only a few patients given 3 drug. So what we do then, we admit them. Our surgeon is on board, because we want a neutral person to monitor the how is the response. And the initial part, they used to visit every day to the patient to see it, how the patient is doing. And we have in house where the system monitors the respiratory rate and oxygen saturation of the patient regularly. But rarely 3 drug. Primarily we have given 2 drug, in these patients, not 3 drug.
Thank you.
But sir, again, highlighting, it is a grade 3 CTC stridor, not grade 4 at all.
Yeah, definitely.
Okay.
Sir, there was a paper, I think, couple of months back on OMCT plus peclicarbo as a NACT.
Yes. So that is a work in progress, and yes, that data looks very promising for us, and we are very keen to explore, and that's why we wanted to be in public domain, because there are a lot of people who are very worried about DCF, and that's a challenge to give in by and large. But looks like as far as the responses are concerned, indirectly, it appears that with the combination you said peclicarbo plus triple metronomic, it looks very promising. It looks very good, in fact.
Yes, sir. Means TPF is straining the resources in most of the setup, or even for patients financially, it is a challenging thing. If we are getting similar response rate with OMCT with plus peclicarbo, then that would be a huge leap forward.
So now, having given to almost 100 odd patients, I won't debate on that. In fact, our Muzaffarpur center, it was a resource constraint, and we had to choose one. And initially, we gave few patients here at TMH Mumbai, and then Muzaffarpur we gave a lot, and that gave us a confidence that it works. And then we have given in TMH Mumbai also. So yes, I do agree. More than one center now we have that responses are good with this combination. And more important, what you said, it is not resource draining.
Sir, one question from Dr. Ankit. GEMCIS versus TPF in nasopharyngeal cancer. Is there any Indian data we have?
GEMCIS versus TPF in which cancer?
Nasopharyngeal
cancer.
Nasopharyngeal. So no Indian data is there. At this moment, what we have do is wherever we have a full resource, we give TPF. Wherever we have a challenging resource, we have given gemcitabine platinum, and we are trying to see. We'll be analyzing our data after some time to see what kind of responses we have. So at this moment, wherever you have a resource issue, we prefer using it here, gem platinum.
My question is regarding some metronomic chemotherapy. So you've got a tremendous experience on metronomic chemotherapy. So currently it is a protocol for palliative. Sir, any trials or any upcoming study you are on for induction as a role, either combining with our routine regimen?
So Rishabh mentioned regarding GEMCIS Chinese paper. I totally agree. That is looks excellent. And that's the reason we are adopting it slowly. Now, coming to your metronomic, yes, metronomic, we just completed a trial of methotrexate celecoxib in patients who were recurrent tumor and then surgery done, and patient was not fit for radiotherapy, and it has been disappointing. And that's the reason we used to use it in between, but now in fact it is a bit detrimental. So I'll say be careful when we use those methotrexate celecoxib, especially in that setting. Coming to metronomic in other setting, there's another study which will be completing, has completed recruitment this year, and hopefully we will have the result by this year and or early next year. That is, induction come maintenance both. But what I'm more excited about is our what we have explored. What is triple metronomic? Because this all data is from double metronomic. Triple metronomic, what is when we combine erlotinib plus methotrexate celecoxib, that looks strikingly different. That will take some more time to explore, because we just completed our phase 2 study in palliative setting, and that paper is JCO. We are completing a phase 3, most likely will get over by this May or June. That may, if it's exciting, if it remains exciting there also, then most likely we will move to neoadjuvant and adjuvant. Because problem is that in head and neck, you're always worried about whatever you want to add, you are complicating that routine process of surgery and radiotherapy and chemoradiation, and that becomes a challenge. So you want to be very careful about whatever you want to bring upfront. So at this moment, no.
Any final comment for by Sir Dr. Kaustubh sir?
Yeah, so this was a very enthusiastic and very thought-provoking discussion. The way I understand from my experience is that head and neck cancer has now not remained as an individually treating disease. This is a multidisciplinary disease. Now, so whenever you think about adjuvant chemotherapy, we must have a clear understanding amongst the team members. The medical oncologist, radiation oncologist, and the surgical oncologist must understand that why we are giving this neoadjuvant chemotherapy. To me, there are three indications. One is, of course, borderline resectable disease. The second, which was, of course, discussed, was organ preservation. And the third, which was not really touched much, which I use in my practice also, are those borderline, meaning T3N0 laryngeal disease or T4 laryngeal disease, which are going outside the laryngeal cartilage but has not invaded the cartilage. They are exolaryngeal disease without involving the cartilage. So these kind of tumors are the tumors where I would give neoadjuvant chemotherapy and see which side the patient is going. If patient is responding excellently, then that patient and is having a functional larynx will go for chemoradiation. And if the patient is not responding well, then that patient will go for surgery. So like we are trying to predict the biology, or we are trying to predict the definitive line of management. So these are the three broad criteria in which I would like to define the patient which needs to undergo neoadjuvant chemotherapy. And I must be very clear with a medical oncologist that what is our end point which we are expecting and what we are going to do if he responds and if he doesn't respond. So that is one thing. And for the borderline resectable cases, when we had a very interesting discussion, all the surgeons, told about what would be borderline resectable and what would be unresectable. As my good friend Dikru says, we must understand a difference between resectability and operability. And that is the crux. And that comes by and that is where the surgeon's input into multidisciplinary team the most important thing. And if that surgeon says that this is a borderline resectable case, it definitely qualifies for neoadjuvant chemotherapy.
Thank you.
Can I make a comment? Dr.
Yes.
Sahu had asked one question. Is it okay? I'll take 10 seconds.
Yes, sir. Yes, sir. Yes, sir.
So Dr. Sahu had asked the question, is there any randomized study for NACT followed by surgery versus radical CTRT? In fact, we were planning, right now also that discussion is going on. When we asked our surgical colleague, put the same criteria, what we do today for NACT for borderline, then it has not been feasible because they say we can't operate them by and large. And that's the reason, Dr. Sahu, we have not been able to till now start that study because what the discussion was that if you put that criteria, what we're doing today, we can't go ahead and remove it because the margins will be compromised in by and large almost every maybe 70-80% of the patients if they do it. So that's the reason we have not been able to do it. Yeah. Just sharing what happened.
So, Dr. Kumar and Dr. Sahu, do you mean that you want to give neoadjuvant chemoradiation instead of neoadjuvant chemotherapy, or you are talking about giving adjuvant chemotherapy, and if patient responds, you want to follow it with chemoradiation rather than surgery? What is the question?
So I think question what Dr. Sahu thought, maybe Dr. Sahu can second it, that we talked about if you don't resect them, these patients will receive chemoradiation. So I think what he wanted to suggest that give only chemoradiation versus the patients giving neoadjuvant chemotherapy, and then you resect part of it and then see what is the outcome here. And answering the question, does the surgery add value here or not? I think so. That's what he thought of asking. There is a paper from Dr. Iyer which has answered this question indirectly from Singapore, that in locally advanced oral cavity cancer, if surgery is not part of the upfront treatment, outcome is poorer. Yeah.
So, Dr. Kumar, taking the cue from all other areas like rectum and esophagus and all, the the option of giving neoadjuvant chemoradiation is a very interesting proposal in head and neck. The problem is, as you rightly said, that the surgeons are really afraid of doing salvage surgery. Surgeons are, really afraid of doing salvage surgery after neoadjuvant chemoradiation. Now, this probably was the case for esophagus and rectum also, but somehow they have been able to, convince the surgeons that that is possible, and then the surgical results are really good after neoadjuvant chemoradiation. So we really don't know. This is an interesting field to explore. But presently, I don't think there is any data to, go for it.
Agree with you, sir.
Thank you, Kumar sir, and hello, Kastub sir, and all the panelists. So after complex discussion regarding the NACT in head